Hello. Welcome to this presentation by FERNE, the Foundation for the Education and Research in Neurological Emergencies. Today we are going to talk about the evaluation of emergency department dizziness patients with new concepts. Today is July 9th, 2020. This is a presentation based on an original podcast provided June 17th, 2020. My name is Edward Sloan. I'm Professor Emeritus at the Department of Emergency Medicine at the University of Illinois at Chicago. I'm an attending physician in emergency medicine at Carle Foundation Hospital in Champaign, Illinois. And I'm Medical Director of the Physician Assistant Studies Program at Dominican University here in River Forest, Illinois. I want to provide a thank you to Sam Skew, who worked with me on the podcast in June, and Jonathan Edlow, who put together the monograph with EB Medicine regarding this new approach to ED patients with dizziness. At the EB Medicine group, I'd like to specifically thank Erica Scott, Angie Wallace, and Stephanie Williford. EB Medicine did support the development of this educational presentation, and I'm also FERNE President and Board Chair, FERNE.org. FERNE works to improve care of patients with neurological emergencies by improving research and education in providers or for patients with neurological emergencies. I have no other financial conflicts. Other parts of this educational lecture and the complete lecture are available at the FERNE.org website or on our YouTube FERNE.org channel. Also available is the June 2020 podcast, which was presented to participants in 46 countries, as well as a CME option on the EB Medicine website at ebmedicine.net, as well as at the specific website address noted below. Please note the disclaimer listed below. In general, this information is intended to augment and not replace the clinical judgment that guides the management of any individual patient. Our educational objectives for this dizziness patient evaluation are as follows. We'd like to enhance competence, that is, knowledge and strategies to use our knowledge in patient care. We'd like to improve performance in practice, and we'd like to improve patient outcomes. Specifically, we'd like to understand dizziness etiologies. We'd like to know how dizzy patients present in the emergency department. We will consider a new diagnostic approach. We hope to be able to diagnose and treat these ED patients. We'd like to discuss dizziness in the setting of the COVID-19 pandemic. And we'd like to be able to record key historical questions and exam findings in the electronic medical record so as to exclude posterior stroke diagnosis, which is the most important diagnosis to consider in patients with dizziness. Our overview for this are as follows. The content literature that provided the basis for this lecture come from the monograph, The Timing and Triggers Approach to the Patients with Acute Dizziness. This was written by Jonathan Edlow, who is an emergency physician. It was published in Emergency Medicine Practice by EB Medicine, December 2019, Volume 21, Number 12. This is a picture of the monograph that appears. Note that EB Medicine has put Emergency Medicine Practice monographs out for the past 26 years, and these monographs are quite useful in providing care of patients with acute emergencies of all types. Please note that in the clinical algorithm, there are some class of evidence definitions as listed below. Obviously, Class 1 recommendations are the best based on the best evidence. Class 2, less secure, less definitive evidence. And Class 3 are the ones that have the weakest evidence and are simply recommendations to be considered. Our dizziness etiologies and diagnoses. Dizziness, as defined by Merriam-Webster, it's an adjective meaning foolish or silly, but it also, from a medical sense, is the having a whirling sensation in the head with a tendency to fall based on the dizziness. It also can suggest being mentally confused. What are our pathologies for dizziness? Systemic causes such as fluid loss, electrolyte imbalance, low hemoglobin, or blood pressure changes can cause dizziness. Peripheral causes, specifically vestibular dysfunction, can also cause dizziness. And then there can be central causes of dizziness, including CNS ischemia, particularly posterior ischemia, and it can be related to CNS events like TIAs or CNS lesions, and we will address all of these during this presentation. What is the normal vestibular anatomy and mechanism? If you go to Figure 2, page 4 of the monograph, you can see the structures that are related to the vestibular peripheral system. The utricle and saccule sense vertical and horizontal acceleration. Our three semicircular canals sense movement in three directions. Our vestibular nerve carries the input from the vestibular system or the peripheral system to the brain from the periphery. Our dizziness case studies. Let's consider a few cases that are relevant to our practice of emergency medicine and the treatment of patients with dizziness in the ED. The first is a 44-year-old dizzy male, and you receive sign-out from your colleague who says, just check the CT. It's a 44-year-old male who's previously healthy. He's had 6 hours of continuous dizziness. He appears to be a little unsteady. He says, I'm feeling like I'm drunk, but he has normal vital signs. He has some left beating nystagmus with gaze to the left. And your colleague says, look, if a CT is okay, send him home with some meclizine. Let's think about that, and we'll consider the case conclusion at the end of this lecture. Another case, a lightheaded 70-year-old. This is a 70-year-old female who's had lightheadedness for 5 days. She says it's worse when she gets out of bed. The dizziness appears to wake her up out of her sleep. She will awaken and then feel dizzy in bed. She's got a history of hypertension. She's on cholesterol and blood pressure meds. Her vital signs are okay. She has a normal neurological exam and no nystagmus. Should a CT be ordered, and why? A third case, a syncopal 58-year-old. This is a 58-year-old male, diabetic, with nausea and vomiting 3 times today. Syncope was reported, but was such bad vertigo, he had to lower himself to the ground. So he didn't actually pass out. He just said he was so dizzy he had to put himself on the ground. This began 3 hours previously. It was sudden. He has nystagmus to the right and higher amplitude gaze to the right. His HIT test is positive. Skew is negative. He is mildly unsteady but has normal gait. Should you call the stroke team? I understand there's a lot of information in this brief presentation, but we will cover it today in our lecture. Our dizziness history. An overview of the dizziness history is important because knowing if the patient is describing lightheadedness or dizziness or vertigo is actually less useful than the timing and triggers approach suggested by Dr. Edlow in this monograph. We know that patients with vertigo are more likely to confirm a sensation of spinning, like on a tilt-a-whirl, but that doesn't actually confirm any particular diagnosis. So we know with vertigo there's some loss of eye control and usually nystagmus, but again, this does not confirm any particular diagnosis and is less useful than the timing and triggers approach suggested by Dr. Edlow. What are our history items? I like the OPQRSTU system. Onset. When? When did it start? Is there a history of the same or similar onset? P, provocative and palliative. In other words, does head movement make it worse? Does lying down with your eyes closed make it better? What is the quality? Is it actually lightheadedness or spinning? R, related symptoms. Are there ENT infection symptoms? Are there neurological stroke type symptoms? S, severity. Is it in general mild, moderate, or severe? T, temporal, and this is very important. Is it intermittent? Is it constant? And has it been constant for several hours and is now present in the emergency department? And U, are they under the care of a clinician? Do they take meds specifically for this dizziness? Next, let's consider dizziness history associated symptoms. Are there infection symptoms, ENT symptoms that might be causing irritation to any portion of the head and neck? Are there chest, GI, or GU symptoms that can be causing fever or dehydration, for example? Are there specific dehydration symptoms, nausea and vomiting, exposure to heat, poor PO intake? Are there specific stroke, posterior stroke, or TIA symptoms? Are there cardiovascular symptoms such as palpitations or apparent orthostatic symptoms due to cardiovascular meds? Is there a history of GI bleeding or anemia? Is there pregnancy a possibility such that we have to consider ectopic pregnancy? Is there a specific history of dizziness or a history of near syncope or syncope related to dizziness? Has there been a history of motor vehicle crash or trauma that could cause cervical artery dissection, either in carotid or vertebrobasilar arteries? So let's look at the dizziness history and the new approach suggested by Dr. Edlow. The ATTEST mnemonic helps us. Is it A, associated symptoms, T, what timing, T, what triggers, E, what examination findings or signs can we see, and T for confirmatory testing based on our specific dizziness exam. Now, this is the clinical pathway for the approach to ED patients with acute dizziness, and there are many parts of it that we will consider today. The dizziness physical and neurological exams are as follows. The general physical exam should look specifically at the vital signs, looking for fever, abnormal vital signs, hypotension, tachycardia, hypertension, or Cushing's findings. Then you need to know, is the patient well appearing? Is there evidence of altered mental status or dehydration? Is there pain or respiratory distress? Is there rash or any skin changes that could suggest some overwhelming infection? Are there dysrhythmias on the monitor? Are there chest, GI, or GU infections evident? Next, we'll look at specifically the HEENT physical exam. Let's look at the ENT exam. Are there sinus or temporal artery tenderness that could cause or be related to sinusitis? Most importantly, pansinusitis. Are there TM or ear canal abnormalities? Is there evidence of pharyngitis or retropharyngeal abscess? Is there evidence of dental abscess, nasal polyps or green discharge that would suggest an ENT infection? Is there neck swelling, tenderness, or bruise? The bruise which could suggest carotid artery pathology. And then also listed as nystagmus, but we'll talk about that in great detail soon. What about the dizziness eye physical exam? We want to know about visual acuity. Is there any evidence of vision loss or peripheral vision loss? What about the visual fields? Is there a specific visual field cut, or is there tunnel vision, loss of peripheral vision? Is there diplopia, either with vertical or horizontal gaze? Are the pupils equally round and reactive to light? In other words, could there be a Marcus Gunn pupil, which would suggest a cranial nerve deficit? Are the extraocular muscles intact? If they're not, this could suggest a cranial nerve 3, 4, or 6 deficit. Is there a lid lag on one side, which could suggest a cranial nerve 3 palsy, which could be related, for example, to an aneurysm? And is the fundus okay? Are the discs sharp, or is there evidence of papilledema? Also, is there a pale fundus, which could suggest an infarct, or is there hemorrhage, which could suggest other fundal pathologies? The dizziness neurological exam. This can be templated in your electronic medical record as well as the other parts of the dizziness exam. We're looking at AVPU, alert, responds to verbal, responds to painful, or unresponsive. Looking at their mental status. How is their speech? Do they have aphasia or dysarthria? The aphasia could be receptive or with speaking. What about motor functioning in the face or extremities? Is there dysmetria, abnormal finger to nose or heel to shin? Is there evidence of truncal ataxia, leaning over in the cart? Could there be a problem with Romberg, or do they have an ataxic wide-based gait? Do they have abnormal reflexes? And lastly, you want to do a general neuropsychiatric assessment. Next, we're going to do the Dizziness Nystagmus Exam. I include this as a separate part of this lecture because it's important that we understand nystagmus as it relates to dizziness and the 6 diagnoses that are principal once we evaluate ED patients with dizziness. So let's talk a little bit about nystagmus and dizziness. So we have both central and peripheral structures that keep our eyes aligned. In the CNS, our occipital cortex, the cerebellum, and the brainstem all help to keep our eyes in the proper position so that we don't experience dizziness as we move. In the periphery, we have the vestibular system that also works to keep our eyes adequately aligned. So our eyes generally move synchronously and follow our head movements without dizziness when we are normal. This allows our body to move around without our eyes constantly causing us to feel dizzy. With nystagmus, there is abnormal eye movement. And when there's abnormal eye movement, there can be dizziness or vertigo as a result, with the sensation either of the room spinning or lightheadedness. And please note that if it's room spinning versus lightheadedness, this does not confirm any one of the 6 diagnoses, as well as the system developed by Dr. Edlow. Now, the Nystagmus exam. Let's talk about it generally. Our eyes normally remain central in our head and they're coordinated to our head movement. If one side of our vestibular system is diseased and is stimulated through gaze, our eyes will slowly drift to the side that is diseased and stimulated. And the drift to the effective side will cause us to have a quick snapback response to correct the location, and that's called nystagmus. So, if our left vestibular system is diseased and sick, our eyes may drift to the left. And in order to accommodate our head movement and to keep us from being dizzy, we have nystagmus snapping our eyes back centrally. So the drift is toward the diseased side, and the snapback is to try to bring our eyes back to a central position. Now, the nystagmus is named for the stimulation, i.e. gaze to the left, and the direction of the quick snapback response, right moving quick nystagmus response. So, our example, we can say with gaze to the right, our eyes are drifting more to the right, and we have a fast snapback to the left, and so it will be called, we have fast left nystagmus based on gaze to the right stimulation. Very technical, but it's important that you be able to describe both what the stimulation is, gaze to the right, for example, and the nystagmus quick response, left quick nystagmus. So again, in background, our eyes normally remain central and coordinated. Our nystagmus causes pathological drift to one side of the abnormal semicircular canal stimulation. Nystagmus comes actually from the Greek word meaning to drift off to sleep. And when nystagmus occurs without any stimulation of the labyrinth system, you need to think of central etiology. In other words, when gaze causes quick beating nystagmus back to the center, that's normally or more often related to the periphery or a labyrinth system problem. If you have, without any gaze in any direction, nystagmus or quick beats, you need to think more about a central etiology of the nystagmus. So let's talk specifically about the nystagmus exam. Have the patient look at you, look at your face centrally from a comfortable position, and then you watch for drift. If, for example, they have some drift and then a quick snapback response, that is nystagmus that you can then document. Most importantly, with this central gaze at you, you need to look for any vertical nystagmus or rotational or torsional nystagmus. Why is that? Because if they have central gaze at your nose, listed in item 2 here, you generally should find an improvement in nystagmus, even if patients are currently dizzy. Let me say that again. When you ask the patient to fix on your face from a comfortable position and they look at your nose with central gaze, nystagmus should generally improve in patients who have a peripheral etiology for their acute vestibular syndrome. If a patient looks centrally at you, no gaze to one side or the other to stimulate the vestibular system. If they look at you centrally and they have upbeating or vertical nystagmus, that's abnormal. If they look at you and they have rotational or torsional nystagmus, that's abnormal. And if central gaze causes them to have worsening lateral gaze or worsening lateral nystagmus, that's abnormal. Once you've established whether with central gaze nystagmus improves, which it should with a peripheral etiology in an acute vestibular syndrome, if it improves, that's a good finding suggesting a peripheral labyrinthine cause. Once you've done that, the third step is to move their eyes in all directions, just to make sure there isn't a cranial nerve palsy 3, 4, or 6. Please note that there are some patients who do have physiological nystagmus, that is nystagmus that's observed without any feeling of dizziness, and this may be seen in patients with pigment disorder specifically. Next, we're going to do the Dizziness Nystagmus Exam. I include this as a separate part of this lecture because it's important that we understand nystagmus as it relates to dizziness and the 6 diagnoses that are principal once we evaluate ED patients with dizziness. So let's talk a little bit about nystagmus and dizziness. So we have both central and peripheral structures that keep our eyes aligned. In the CNS, our occipital cortex, the cerebellum, and the brainstem all help to keep our eyes in the proper position so that we don't experience dizziness as we move. In the periphery, we have the vestibular system that also works to keep our eyes adequately aligned. So our eyes generally move synchronously and follow our head movements without dizziness when we are normal. This allows our body to move around without our eyes constantly causing us to feel dizzy. With nystagmus, there is abnormal eye movement. And when there's abnormal eye movement, there can be dizziness or vertigo as a result, with the sensation either of the room spinning or lightheadedness. And please note that if it's room spinning versus lightheadedness, this does not confirm any one of the 6 diagnoses, as well as the system developed by Dr. Edlow. Now, the Nystagmus exam. Let's talk about it generally. Our eyes normally remain central in our head and they're coordinated to our head movement. If one side of our vestibular system is diseased and is stimulated through gaze, our eyes will slowly drift to the side that is diseased and stimulated. And the drift to the effective side will cause us to have a quick snapback response to correct the location, and that's called nystagmus. So, if our left vestibular system is diseased and sick, our eyes may drift to the left. And in order to accommodate our head movement and to keep us from being dizzy, we have nystagmus snapping our eyes back centrally. So the drift is toward the diseased side, and the snapback is to try to bring our eyes back to a central position. Now, the nystagmus is named for the stimulation, i.e. gaze to the left, and the direction of the quick snapback response, right moving quick nystagmus response. So, our example, we can say with gaze to the right, our eyes are drifting more to the right, and we have a fast snapback to the left, and so it will be called we have fast left nystagmus based on gaze to the right stimulation. Very technical, but it's important that you be able to describe both what the stimulation is, gaze to the right, for example, and the nystagmus quick response, left quick nystagmus. So again, in background, our eyes normally remain central and coordinated. Our nystagmus causes pathological drift to one side of the abnormal semicircular canal stimulation. Nystagmus comes actually from the Greek word meaning to drift off to sleep. And when nystagmus occurs without any stimulation of the labyrinth system, you need to think of central etiology. In other words, when gaze causes quick beating nystagmus back to the center, that's normally or more often related to the periphery or a labyrinth system problem. If you have, without any gaze in any direction, nystagmus or quick beats, you need to think more about a central etiology of the nystagmus. So let's talk specifically about the nystagmus exam. Have the patient look at you, look at your face centrally from a comfortable position, and then you watch for drift. If, for example, they have some drift and then a quick snapback response, that is nystagmus that you can then document. Most importantly, with this central gaze at you, you need to look for any vertical nystagmus or rotational or torsional nystagmus. Why is that? Because if they have central gaze at your nose, listed in item 2 here, you generally should find an improvement in nystagmus, even if patients are currently dizzy. Let me say that again. When you ask the patient to fix on your face from a comfortable position and they look at your nose with central gaze, nystagmus should generally improve in patients who have a peripheral etiology for their acute vestibular syndrome. If a patient looks centrally at you, no gaze to one side or the other to stimulate the vestibular system. If they look at you centrally and they have upbeating or vertical nystagmus, that's abnormal. If they look at you and they have rotational or torsional nystagmus, that's abnormal. And if central gaze causes them to have worsening lateral gaze or worsening lateral nystagmus, that's abnormal. Once you've established whether with central gaze nystagmus improves, which it should with a peripheral etiology in an acute vestibular syndrome, if it improves, that's a good finding suggesting a peripheral labyrinthine cause. Once you've done that, the third step is to move their eyes in all directions just to make sure there isn't a cranial nerve palsy 3, 4, or 6. Please note that there are some patients who do have physiological nystagmus, that is nystagmus that's observed without any feeling of dizziness, and this may be seen in patients with pigment disorder specifically. So as we consider nystagmus, I want to bring forward now Dr. Edload's new approach to the dizziness exam. Remember his dizziness history, ATTEST. And now let's take a look at the clinical pathway, which has 3 portions highlighted. We're asking 3 general questions. What about any cause that could be related to a general medical cause such as dehydration? Then we want to establish whether there's an acute vestibular syndrome. And lastly, if it's not an acute vestibular syndrome, we want to know whether the intermittent dizziness is triggerable or it occurs spontaneously. So, the reason I bring this up is as follows. I'm going to talk about now causes of what are likely central causes of nystagmus, and these bad types of nystagmus are suggestive of a central etiology, not labyrinthine, only in the setting of an acute vestibular syndrome. My point here is this. If a patient has acute, severe, persistent vertigo at presentation, there are nystagmus findings that suggest a central etiology. So someone comes in with 5 hours of severe, constant dizziness, that's acute vestibular syndrome. And in an acute vestibular syndrome, here are the following things, the types of nystagmus that suggest a central etiology. Number one, without gaze stimulation, an apparent constant lateral nystagmus that occurs with central gaze. Another bad type of nystagmus that suggests central etiology is vertical or torsional nystagmus. Vertical, up and down. Torsional or rotational, which is circular. Those types of nystagmus and acute vestibular syndrome are suggestive of a central etiology. Again, we stated that with central gaze at your face, no stimulation of gaze side to side, if the nystagmus appears to worsen, that's a likely central cause. And lastly, a lateral nystagmus that changes its fast component with gaze to both sides. In other words, if you have gaze to the left and then you have quick nystagmus right, and with gaze to the right, you have quick nystagmus left, in acute vestibular syndrome, that again suggests a central etiology. So what are those again? In acute vestibular syndrome, those nystagmus findings that suggest a central etiology such as posterior stroke, they include pure lateral horizontal nystagmus without gaze stimulation, vertical nystagmus, rotational or torsional nystagmus, worsening nystagmus with central gaze, and lastly, lateral nystagmus that changes its fast component direction with gaze to each side. Gaze to the left, quick nystagmus right. Gaze to the right, quick nystagmus left. All of these are considered bad or likely central cause findings with acute vestibular syndrome. The reason I keep pointing out the concept of these are bad findings in acute vestibular syndrome is this. With posterior canal BPPV, the nystagmus often can be vertical and or rotational. And in horizontal canal BPPV, the nystagmus is horizontal and direction changing with gaze. And so it's important to know that with triggered episodic vestibular syndrome, specifically the diagnosis of BPPV, these are benign findings. But with acute vestibular syndrome, these are considered serious findings because they suggest a central etiology. Therefore, your nystagmus interpretation depends on the presumed diagnosis, either acute vestibular syndrome, in which these findings are considered serious, or triggered episodic vestibular syndrome, specifically BPPV, in which case these findings can be found to be with this peripheral diagnosis. I understand that this is a very confusing topic. I suggest you listen to this a few times, but remember, only one concept drives this. Your interpretation of nystagmus findings is dependent upon whether or not, prior to assessment for nystagmus, the patient appears to be presenting with an acute vestibular syndrome, or they just have what sounds like triggered episodic dizziness or episodic vestibular syndrome, in which case BPPV is the more likely diagnosis. So, what is the nystagmus exam requirement? You must establish if the nystagmus exam is being done in the setting of either suspected acute vestibular syndrome, AVS, or triggered episodic vestibular syndrome, or TEVS, which suggests BPPV or a peripheral cause. In AVS, or acute vestibular syndrome, the bad nystagmus signs are worrisome, and in triggered episodic vestibular syndrome, these same, quote, bad nystagmus signs are benign, or more likely benign due to peripheral vestibular etiology in BPPV, which is due to an otolith problem in your semicircular canals. So remember, before determining your nystagmus exam interpretation, you need to determine the likely etiology first and examine the setting of AVS or triggered episodic vestibular syndrome. So, we had a list of bad Nystagmus suggesting central findings for acute vestibular syndrome. However, in BPPV, a triggered episodic vestibular syndrome, there's only one nystagmus finding that may be suggestive of a central etiology. In a patient with a presumed peripheral etiology or BPPV in triggered episodic vestibular syndrome, if with gaze to you centrally, the nystagmus appears to worsen, this is the one finding that may suggest a central etiology, even if the exam sounds more, or the history sounds more like a triggered episodic vestibular syndrome and likely BPPV. So, our central gaze key concept to reiterate. In general, nystagmus that is related to a peripheral vestibular problem will improve with fixed central gaze to your face at a comfortable distance. So you ask the patient to look at your nose from a comfortable distance right in front of them. If with fixed central gaze at your nose, the nystagmus does not improve or worsens, then you should suspect a central etiology of the nystagmus, again, because peripheral causes generally improve with central gaze fixation. The next thing to consider with dizziness patients in the ED is the issue of neuroimaging. Let's talk just generally about non-contrast head CT. We know there's a low yield for positive findings, generally less than 10%. Despite this low yield, head CT in the emergency department, non-contrast, has a high clinical utility. It's accurate and it allows us to make a disposition that might include being able to send the patient home because we know their head CT is negative. In general, non-contrast CT is the initial test of choice in all ED patients that require neuroimaging. It's useful to exclude subarachnoid hemorrhage, other types of hemorrhage, abscess, space-occupying lesion, edema, mass effect, and or midline shift. Now, in dizziness, we know that only 1.6% of patients with a non-contrast head CT who are dizzy in the ED will have any positive findings related to the symptoms that they present with. ICH, or intracerebral hemorrhage, rarely presents as an isolated acute vestibular syndrome. And in dizziness patients, intracerebral hemorrhage is only seen in 0.5% of cases or less, that is 1 in 200 or less. We know that if there's a headache and CPPV findings, we should consider CT. The CPPV is a central etiology for what appears to be a peripheral triggered vestibular syndrome, and we're going to talk about that specifically coming up. What about MRI neuroimaging in dizzy patients? We know that DWI, or diffusion weighted imaging in MRI, can miss stroke in the first 48 hours. So in acute ischemic stroke, a negative DWI MRI can be seen in up to 7% of patients, and in fact most of these are patients with posterior stroke, which of course is the stroke of concern in patients who present with dizziness. So in acute vestibular syndrome, DWI MRI can be negative in 12 to 18% of patients when performed in the first 72 hours. So we know that MRI can be negative despite the presence of stroke, and that's of concern, and that's why our exam and history must be competent and be able to diagnose likely posterior stroke, because our neuroimaging may not help us as much as our history and physical exam. In small strokes, for example, DWI MRI can be negative in up to 50% of patients, especially early. We know that we should consider large vessel disease in most patients in whom we suspect stroke, in which case doing an initial CT may lead us to consider the need for TPA in the emergency setting. So let's do a question related to dizziness and neuroimaging. Which statement about brain imaging in patients with acute dizziness is true? So one statement is going to be true. In patients with BPPV, a brain MRI can help establish the diagnosis. Doesn't sound like it's true. We know that MRI can miss the diagnosis, especially early. Number 2, B, in posterior circulation stroke, CT is diagnostic in greater than 75% of cases. Again, that doesn't sound true. In posterior stroke, CT can be negative quite often. C, in patients with posterior circulation stroke, early MRI with diffusion-weighted images establishes the diagnosis in nearly all patients. That again doesn't sound true because early MRI can be negative, as we just stated. And D, in patients with vestibular migraine, which we'll address soon, neither CT nor MRI is indicated. That's probably true because we know that with vestibular symptoms and dizziness, CT and MRI often are not helpful. So the answer to this is D, neither CT or MRI is indicated. A key point is that not only is imaging not required, but in fact has serious limitations in patients with posterior circulation stroke. So we know that CT and MRI, although assuring or reassuring, they do not help specifically with making the diagnosis, and this was actually seen on page 15 of the monograph. Let's talk about this new approach and explain it as based on what Dr. Edlow has provided to us. Our history, again, is the mnemonic ATTEST, associated symptoms, timing, triggers, examination signs, and confirmatory testing. This, again, is the clinical pathway, and we have circled in yellow the 4 areas that help us. Is there a general medical cause without stroke symptoms or findings? Does there appear to be a severe constant acute vestibular syndrome? And if not, if it's intermittent or episodic, is it triggered and or spontaneous? So there are 3 steps to this ATTEST evaluation and clinical pathway that we do. Is the medical screening exam normal? Is the dizziness now constant and continuous? And if there's intermittent dizziness, is it spontaneous or triggered? Our ATTEST evaluation using this clinical pathway. We first want to know if there's a general medical etiology such as dehydration. If there is and there's no evidence of stroke, then we just treat the medical etiology. We then want to say, is there constant dizziness? Is it sudden, severe, going on for hours? They present to the ED with this constant dizziness, in which case it's an acute vestibular syndrome. And lastly, if it's not constant at the time of presentation, but more often intermittent, is it triggered? In which case it's a triggered episodic vestibular syndrome. Or is it spontaneous? A spontaneous episodic vestibular syndrome. Here again is the pathway. Now we'll go through parts of it specifically. The red rectangle now has highlighted the portion that includes a general medical cause. So, in your electronic medical record, you want to address medical symptoms and whether or not there are stroke signs. In other words, is there a positive general medical symptom or sign that suggests a specific cause such as dehydration? If there is, then you want to point out that there's no evidence of a likely posterior circulation stroke. You would then say there's no vertical or rotational nystagmus. There's no arm dysmetria or clumsiness or cerebellar finding, and no arm weakness. There's no vision, speech, swallowing, or sensory changes. There's no truncal ataxia or gait abnormalities. Therefore, there doesn't appear to be a stroke, specifically posterior stroke, in this dizzy patient. If you can document all of those in the electronic medical record, then you can treat the presumptive medical cause, and you will have established that you considered the more serious posterior stroke diagnosis, but did not find it at the time of ED presentation. The next red triangle then addresses the presence of an acute vestibular syndrome. So in the electronic medical record, the thing that you want to do next, if you've demonstrated that there's no apparent general medical cause based on symptoms and signs, you then want to say, is the dizziness constant and persistent? If yes, you've diagnosed an acute vestibular syndrome. If there is not a constant, sudden, severe onset of dizziness that is not currently present in the ED, and instead the dizziness is triggerable, you then have to consider whether it's spontaneous or episodic. If you look at this next slide, in the clinical pathway, we've now put a rectangle around whether or not the dizziness is triggerable. If there's no acute vestibular syndrome diagnosis, and therefore there is episodic dizziness, you want to consider the trigger question. And if it's episodic, you want to ask the simple question, is this intermittent episodic dizziness triggered or spontaneous? If it's triggered by something, rolling around in bed, moving your head, then you would suggest triggered episodic vestibular syndrome or triggered EVS. If no, it's not triggered, but it occurs spontaneously without any precipitant, you would then say it's spontaneous episodic vestibular syndrome or SEVS. Again, we see the pathway that we've gone through all three parts. General medical cause, acute vestibular syndrome. If none of those, it's either spontaneous or triggered episodic vestibular syndrome. So our ATTEST summary and this clinical pathway. General medical etiology with no stroke symptoms, treat the general medical etiology. If it's constant, sudden, severe dizziness, consider an acute vestibular syndrome and make it one of your diagnoses in the electronic medical record. If you've made the diagnosis of acute vestibular syndrome and you put that in your electronic medical record, you then can consider two specific diagnoses in acute vestibular syndrome. The first is vestibular neuritis / labyrinthitis or posterior circulation stroke. If it's intermittent dizziness, remember it's either triggered or spontaneous. In triggered EVS, it's either BPPV or orthostatic hypotension. And if it's spontaneous EVS, it's vestibular migraine or TIA. And those will sound like some type of spell that happen intermittently, spontaneously, but seem very similar in their presentation or symptomatology. So we have 3 diagnostic strata and 6 main diagnoses. If it's acute vestibular syndrome, it's either vestibular neuritis or labyrinthitis or a posterior stroke. If it's triggered EVS, it's either BPPV or orthostatic hypotension. And if it's spontaneous EVS, it's either a vestibular migraine or a TIA, some type of circulation and ischemic spell of the central nervous system. So, again, our clinical pathways and ATTEST diagnoses. List of 6 diagnoses are as follows. AVS, 2 diagnoses. Triggered EVS, 2 diagnoses. Spontaneous EVS, 2 diagnoses. 3 main diagnostic strata and 6 main diagnoses. I go over this repeatedly because I believe every time that you now see a dizzy patient, you should be able to think that if there isn't some apparent general medical cause and the absence of stroke, you now can boil it down to 3 strata and 2 diagnoses each. And if you have those 6 diagnoses in a dot phrase in your electronic medical record, it should be possible then to pick one of those 6 so that a dizzy patient will either present with acute vestibular syndrome and it's going to be one of 2 diagnoses that follow, or if it is a intermittent dizziness, you will list it as either spontaneous or triggered, and then you will list one of 4 possible diagnoses. So, we'll ask another question regarding dizziness characteristics. Patients with an acute onset of dizziness that is persistently present and present at the time of examination in the ED have which of the following vestibular syndromes? A, acute vestibular syndrome, B, triggered episodic, C, spontaneous episodic, or D, chronic vestibular. And we know the answer, that is constant, severe, present at the time of presentation, is A, acute vestibular syndrome, seen here and explained on the next slide. Seen on page 6 of the Timing and Triggers Approach monograph. The next part we are going to do is acute vestibular syndrome bedside diagnostic testing. I include this as a separate part of this lecture because it's important to know that there are 5 different tests that you can do to make sure to be able to exclude posterior stroke in patients who present with an acute vestibular syndrome. I have a red rectangle around these 5 exam findings on the clinical pathway that are listed, because if any of these 5 is positive, you need to consider a stroke diagnosis for the acute vestibular syndrome. Now, of course, this is the most important thing we do as emergency care providers in the emergency department. Why? We first need to rule out life threats, and posterior circulation stroke is an important life threat. I've known colleagues who have had cases of young patients who present with dizziness who have progressed within the first 24 to 48 hours to posterior circulation stroke symptoms, and this can be catastrophic, especially if you have posterior cerebellar swelling in a fixed space that requires operative intervention, and it can often cause catastrophic outcomes. So this part of this lecture that includes the 5 exams findings that we need to exclude is an important part of what we do in this dizziness evaluation. Remember, 3 diagnostic strata, 6 diagnoses, 1 of them is posterior stroke, and these 5 findings, or the absence thereof, will allow us to exclude posterior stroke. So, acute vestibular syndrome posterior stroke findings. We are looking for stroke signs on our exam. 5 tests are performed. If any specific findings are noted, then a stroke must be considered. That's important because if you're considering posterior stroke, you should contact the stroke team even if it doesn't appear as though TPA is indicated for IV use in the emergency department. So, what are these findings? Abnormal nystagmus, vertical skew deviation, not a positive hit test, stroke findings specifically, or ataxia. All of these would suggest a central etiology and a possible posterior circulation stroke. What are the specific stroke findings that I just stated? I'll say them again because these 5 are listed in the monograph, but it is important to know these, and you can put this in the electronic medical record. Central pattern or bad nystagmus in the setting of acute vestibular syndrome. Skew deviation or movement of one eye up vertically with a vertical correction when you uncover one eye and expose the other. The absence of a unilateral corrective saccade or movement to the center on hit exam is a finding that suggests posterior circulation stroke. CNS signs on a neurological exam, such as arm dysmetria or clumsiness, would suggest a posterior stroke. And anytime a patient is unable to sit or walk unassisted, you must consider a posterior stroke even in the setting of acute dizziness. That is to say, you might assume that dizziness and nystagmus will cause all patients to have ataxia. This is not true. Patients with peripheral vestibular cause of dizziness should have normal truncal function and normal gait, even if dizzy. And my point is this: if a patient cannot walk, you need to consider this gait ataxia as a possible central etiology and a posterior circulation stroke. So, in Table 2 in the monograph, I've put a red triangle or a red rectangle around the exam component and what is considered peripheral, and next slide, what is considered central. You need to take a look at this because it's important to know which are those that suggest a posterior circulation stroke etiology and what needs to be excluded, in other words, to be able to say that it is a peripheral etiology. We're now going to look at the 5 different exam findings and distinguish those findings which suggest a peripheral versus a central etiology. So, acute vestibular syndrome, remember all the abnormal nystagmus findings are of concern in acute vestibular syndrome, even though they might occur in BPPV, which is peripheral. So let's stick to the acute vestibular syndrome, nystagmus. What are things that would suggest a peripheral etiology? Horizontal nystagmus with stimulation and a fixed horizontal movement, only fast to one side, regardless of whether gaze goes to one side or the other. So peripheral is considered as the possible etiology when it's horizontal nystagmus with stimulation and a fixed horizontal fast movement. That is, fast correction in one direction, suggesting one peripheral side with illness. What AVS nystagmus findings suggest a central etiology? Horizontal nystagmus that occurs without any gaze to one side or the other, that occurs just on its own, with the patient looking forward, this would suggest a central etiology. Vertical nystagmus, torsional or rotatory nystagmus, and or directional changing horizontal fast movement. That is, gaze to the left, quick right. Gaze to the right, quick left. All of these suggest a possible central etiology for the dizziness as we discussed in our nystagmus section. Now, what is the test of Skew? You cover one eye, then uncover the other alternately. Now, when you do this, if there's a peripheral etiology to the dizziness, there's no vertical skew deviation. The pupil won't be skewed one way or the other on a vertical axis. So when there's no vertical correction with one eye then the other being exposed, this suggests a peripheral etiology. If, however, that when you uncover one eye and then the other, the pupils appear to be offset in a vertical axis and they need to correct, this would suggest a central etiology. So vertical correction as the eye is uncovered to get both pupils to be aligned on the vertical axis, this would suggest a central etiology. This is similar to having vertical nystagmus where your eye is going up and down abnormally, which is a bad finding in acute vestibular syndrome. The head impulse test. Now, this test I've identified on this slide in red is only verified to be useful in patients with nystagmus. That is the rotatory feeling and some nystagmus observed on physical exam. And what we're doing is looking for some asymmetry in the vestibular response. So what do? You hold the head 15 degrees to each side and then you move it quickly to the center. So left, center, right, center. If there's a peripheral etiology, that is, one peripheral vestibular system or the other is diseased, faltering, failing. If that's the case, when you move the head to one side or the other, there will be a corrective saccade. For example, I move the head to the left and then move it centrally. The eyes will tend to run a little past where they're supposed to and have a quick saccade or movement right back to the center in order to get the eyes and pupils in the center of the head. That would suggest that there is some illness on the right side that caused the eyes to drift in an additional direction with movement from the left to the center. If the left side is diseased, when you move the head to the right and to the center, the eyes will drift to the left because the left side is abnormal or diseased with neuritis or labyrinthitis. So what I'm saying is this. If you are considering a peripheral etiology, there should be a unilateral fast saccade to the center seen with eye movement suggesting a vestibular problem. In other words, having a fast saccade with movement to the center from one side or the other. If you observe a fast saccade on one side or the other, this is a good finding. It is a positive finding, and a positive finding suggests a peripheral etiology, suggesting that one side or the other in your vestibular system is failing. What would suggest a central etiology? If when you move the head from the side centrally, from both sides, and there is no corrective saccade on one side or the other, this suggests that there is no peripheral or labyrinthine abnormality and that the problem could be a central problem. So again, if there's no unilateral correcting saccade on one side or the other, then you must consider either it's no posterior stroke or a possible posterior stroke. So Figure 5 on page 12 of the monograph shows you pictures of this HIT test. And it shows how the eyes follow the rotation to the disease side with a correcting saccade to the center. So if your right side is sick, move from left to center, the eyes will go an additional movement toward the right sick vestibular side and then recorrect. If there's a left side that's sick, move from the right to the center, the eyes will lag and go further to the left and have a corrective saccade to the center. So a unilateral compensatory saccade suggests a peripheral vestibular etiology of the dizziness. If there is no compensatory saccade bilaterally, no quick saccade on either side, no lag, no suggestion of a diseased vestibular syndrome system on one side or the other, and your eyes are correcting automatically on their own, this suggests that the vestibular system is working normally, and then you must think a possible central etiology such as a posterior ischemic event. So, head impulse test language in our electronic medical record. It's only performed in patients with nystagmus. It's performed in patients with acute vestibular syndrome to exclude stroke, posterior system stroke. In normal patients, there will be no correcting fast saccade, and in those with a possible central etiology such as posterior ischemic stroke, there's no correcting fast saccade. So, if there's a unilateral corrective saccade to the center with a turn from one side to the other or the other to the center, this suggests a vestibular etiology with a unilaterally sick or diseased side. So a unilateral eye saccade with the HIT test in patients with acute vestibular syndrome and evidence of nystagmus, a unilateral eye saccade is correct. It's good. It suggests one sick vestibular side, and then it suggests that there's a peripheral diagnosis or etiology of the dizziness. No saccade on one side or the other suggests that there isn't a peripheral cause on one side or the other, and that you need to think a central etiology or a posterior ischemic event. Next, we're going to talk about the fourth thing we must consider to exclude posterior stroke, and that is evidence of specific neurological exam findings that suggest a posterior event. So, if it's a peripheral etiology, there should be no findings. There should be no cranial nerve, brainstem, or cerebellar findings. What would suggest a central etiology or stroke findings? Limb ataxia, weakness or clumsiness of the arms or legs, dysarthria, hearing loss, dim vision, pain or temperature sensory loss, not light touch, but pain or temperature sensory loss, and or diplopia, ptosis, or anisocoria. All of these might be findings that would suggest a central etiology or posterior ischemic event as the cause of the dizziness. The fifth and last posterior stroke finding, which must be included, really addresses truncal ataxia and the ability to have a normal non-ataxic gait. If it's a peripheral etiology to the dizziness, there should be no findings. The patient should be able to sit in the cart or chair without having to hold on, and the patient should be able to walk without a wide base ataxic gait. A central etiology is suggested if the patient is unable to sit without holding on or unable to walk assisted. That is to say, every dizzy patient has to be able to walk out of the emergency department. If they remain so dizzy that they have to be put in a wheelchair to get to their car because they can't walk, that patient needs to be admitted and observed for suspected central etiology or posterior circulation ischemia etiology of the dizziness. So let's do another question, dizziness and nystagmus. In patients with acute vestibular syndrome, nystagmus findings that suggest a central cause include all of the following except, so which ones are true? Unilateral or unidirectional horizontal nystagmus, B, torsional nystagmus, C, vertical nystagmus, D, direction changing horizontal nystagmus, which is gaze evoked. And we know the answer, which one is false, that is not a sign or likely central cause suggestion, that is unilateral or unidirectional horizontal nystagmus. The others, torsional, vertical, and direction changing nystagmus, all suggest a central etiology, and that's seen here. Answer A is the one that is not correct or not a central cause, and that's from page 10 of the monograph. So again, in acute vestibular syndrome, let's look at our electronic medical record statements. We have 5 different findings that are in the red rectangle in the clinical pathway. So our 5 questions. Is there central pattern nystagmus? You can say in the medical record, vertical, rotational, pure lateral with no stimulation, or lateral nystagmus that changes direction with gaze. All of these are not found. Is there skew deviation? You can say there is no vertical skew deviation. Is the HIT test negative or not okay? You can say there is the presence of a unilateral correcting fast saccade on one side, which is good, positive, suggesting a peripheral labyrinthine etiology. You can say, are there CNS signs on neuroexam? There are no CNS neuroexams which suggest posterior ischemic stroke. And you can ask, is the patient able to sit and walk assisted? You can say the patient is able to sit and walk unassisted. So our 5 statements: no central pattern nystagmus findings are seen. No vertical skew deviation is observed. A positive, which is good, unilateral corrective HIT exam is seen, which suggests peripheral etiology. There are no stroke CNS signs on neurological exam, and the patient is able to sit and walk unassisted. These findings allow the diagnosis of vestibular neuritis or labyrinthitis to be made in this patient with acute vestibular syndrome, as posterior stroke is reasonably excluded. This is such a powerful list of statements that can be put into a dot phrase with every patient who presents with dizziness and acute vestibular syndrome. Let's talk about our specific diagnoses. Remember, we had 3 strata, 6 diagnoses. Now let's talk about these specific diagnoses. So we have the 3 strata: acute vestibular syndrome, spontaneous episodic vestibular syndrome, and the triggered episodic vestibular syndrome that leads to these diagnoses. Acute vestibular syndrome. I've got the red rectangle around the common benign causes and the common serious causes and some rare causes. Let's go through them. Vestibular neuritis or labyrinthitis is a peripheral benign etiology of dizziness. It's most often a viral etiology, but other etiologies can cause patients to have vestibular neuritis or labyrinthitis, including bacterial middle ear infection, meningitis, CNS infection, injury or tumor, and/or a medicine side effect. Now, labyrinthitis. It's a peripheral benign etiology. It is an inflamed labyrinth or inner ear which transmits abnormal input to the brain through what could be a normal or also diseased vestibular nerve. Please note that both vestibular nerve and labyrinth abnormalities or inflammation can occur at the same time. And therefore, it's hard really to distinguish one from the other, whether it's neuritis or labyrinthitis. So what about vestibular neuritis? Same thing, peripheral benign etiology. It's an inflamed vestibular nerve which transmits input from the labyrinth or inner ear to the brain. So what can happen with neuritis is, although the labyrinth is normal, the vestibular nerve, which carries the input from the labyrinth peripherally to the central brain, is diseased and therefore doesn't transmit input normally, such that the corrective labyrinthine activities can't be activated by the brain centrally. Again, the same other etiologies can cause vestibular neuritis. So, what's the treatment of vestibular neuritis and/or labyrinthitis? Steroids to reduce inflammation, antihistamines such as meclizine for symptomatic relief. You might consider antivirals since it's most often a viral etiology. You need appropriate home support and close follow-up. You need hospital admission for those with questionable signs and symptoms, in which case you can exclude posterior ischemic circulation problems. And you must note again that posterior circulation symptoms can progress quickly, and so observation for 24 to 48 hours, if there's any doubt, with stroke team consultation is a good idea. Now, the other cause of acute vestibular syndrome we've talked about repeatedly is posterior circulation stroke symptoms. This is a central serious etiology. It is the most important dizziness etiology that we consider. The dizziness and vertigo, you know, can occur with all different types of diagnoses. It can occur with posterior circulation stroke, but the presence of it doesn't make it a posterior stroke, and the absence of dizziness and vertigo doesn't exclude posterior stroke either. We often will see nausea and vomiting and vertigo with the posterior stroke symptom, with the disease, but not always. And we know that we see nystagmus, but it can also be seen with BPPV. What are the findings that would suggest posterior stroke in a patient with acute vestibular syndrome? Headache, not common in BPPV. Headache is more likely with posterior circulation stroke. Dim vision, diplopia, limb weakness, dysmetria, sensory changes, especially pain and temperature, dysarthria, dysphagia, truncal ataxia, ataxic gait. These are findings that are unique posterior circulation ischemia signs and symptoms not seen with our more benign BPPV diagnosis. These are some other rare AVS diagnoses that are listed, including MS, Wernicke's encephalopathy, drug effects, or toxicities. Now, let's talk about our spontaneous episodic vestibular syndrome diagnoses. One quick note on quote spells. Recurrent similar non-provoked episodes or spells should be addressed systematically. We should consider a possible seizure etiology. We should consider complex partial seizures as a possible cause. Patients with the seizure disorder may have dysconjugate gaze at baseline, especially those with autism, and you must note that prior to examining these patients. CNS ischemia may also be the cause of spells, including posterior circulation stroke and/or TIA, and posterior circulation ischemia should be considered, or posterior circulation TIAs, if the patient has recurrent, similar spontaneous dizzy episodes. So now we're going to talk about spontaneous episodic vestibular syndrome. Again, the second strata in the red rectangle. Now, vestibular migraine is a benign peripheral possible etiology to spontaneous episodic vestibular syndrome. How do you make the diagnosis? From Table 3, page 13, you need to have at least 5 episodes of moderate to severe symptoms. These can last between 5 minutes and 72 hours, quite a wide time span of duration. A history of migraine headaches is common. The migraine headache features should be seen with at least 50% of the vestibular migraines. So headache with migraine characteristics and aura, phonophobia, photophobia, or some type of visual aura. Meniere's disease, also a peripheral benign etiology. Patients will have vertigo and drop attacks related to this disease state. There can be tinnitus, hearing loss, ear pressure or pain. It's usually unilateral. It's treated with salt and fluid control. And at times there's external devices or surgery that may be required. So Meniere's, unilateral hearing loss, a simple way to check for hearing is to move your fingers one ear on the other. And if they say they can hear it on one side and they're deaf to it on the other, that would suggest possible Meniere's disease. Now, we are talking about spontaneous episodic vertiginous syndrome or symptoms. If it's episodic, spontaneous, it could be a posterior circulation TIA. This is more central, a more serious etiology. Up to half of posterior circulation TIA patients have dizziness as the only symptom. And the symptoms can be related to the long brainstem tracts that are found in the CNS. There can be some CNS nerve dysfunction or cranial nerve dysfunction. There can be visual field cuts because the posterior cerebral artery supplies the visual cortex, and in the presence of ischemia, there can be visual field cuts. And these patients are considered high-risk TIAs as compared to those with anterior circulation because it can progress quickly to a posterior circulation stroke with the attendant complications seen there. There are some rare spontaneous EVS diagnoses such as, or less common, cardiac dysrhythmias, pulmonary embolism, seizure disorder, or panic attacks and/or anxiety disorders. And I have to comment that although these are listed as rare, these actually are more common disease states that you must consider with spontaneous, episodic, vertiginous vestibular syndrome presentations. What about triggered episodic vestibular syndrome? Now, this is the third strata that we have, and it's again here in the red rectangle. And let's go through these. Now, triggered episodic diagnoses, what do we mean? There are specific triggers that induce symptoms. A change in head position, or standing up, or movement of the head. It normally lasts less than 1 minute. These patients can be seen to have panic attacks or anxiety disorders, but again, these are diagnoses of exclusion because they may have anxiety really because they're getting dizzy and they're worried that it could be a stroke. These patients are generally not dizzy at baseline. And what I'm talking about is if patients have baseline dizziness and it gets exacerbated or worsened, but at baseline they have some dizziness, this is more commonly seen in acute vestibular syndrome, not episodic vestibular syndrome. So, BPPV, I'll finally tell you, is benign, paroxysmal, positional, vertigo. It is peripheral. It is a benign etiology. These are very brief episodes of dizziness. There are episodes that wake the patient up from sleep or they wake up and are profoundly dizzy. The dizziness can occur with lying down or turning their head in bed. And when you get this symptom, the positive likelihood ratio is 60, which is huge, which means if they tell you that when they're lying down and they turn their head in bed or they wake up with dizziness in bed, this is likely BPPV or benign paroxysmal positional vertigo. This is most often the posterior canal, and this is the type of intermittent triggered dizziness that is diagnosed with the Dix-Hallpike test or sometimes the supine head roll test. Now, a BPPV important nystagmus note. Remember, when you have these central nystagmus signs, such as rotatory, vertical, or changing direction nystagmus, or unprovoked nystagmus to one side, these in AVS are considered central. But when you're considering BPPV, which is a triggered event, not acute vestibular syndrome, you can have these abnormal nystagmus findings and they are not suggestive of a central etiology. In other words, in posterior canal BPPV, the nystagmus is vertical and or rotational. In horizontal canal BPPV, the nystagmus is horizontal and direction changing with gaze, which we had said with acute vestibular syndrome is suggestive of central. In this case, it is not. These are benign findings in triggered EVS BPPV, but are worrisome in acute vestibular syndrome. So again, nystagmus interpretation depends on if the symptoms originally suggest acute vestibular syndrome or a triggered episodic vestibular syndrome, including BPPV. Now, I mentioned central paroxysmal positional vertigo. I must admit that this is a serious concern. It's the one other concern besides a posterior circulation event. The central paroxysmal positional vertigo is from a central or serious etiology. It occurs when there are structural lesions adjacent to the fourth ventricle. It can occur in the setting of tumor, MS plaque, or a small brainstem stroke. These patients often will present with headache, diplopia. They frequently recur. There's abnormal cranial nerve function or abnormal cerebellar function. There can be downbeating or non-extinguishing nystagmus. That is to say, most times when you have lateral nystagmus, it'll extinguish and lessen over several seconds. If it continues and it's severe and it does not appear to extinguish, this might suggest a central etiology of the intermittent triggered paroxysmal positional vertigo. And if you have nystagmus in isolation that's new, without dizziness, this again would suggest a central etiology. And lastly, if there's no or poor response to our positional maneuvers that are designed to improve dizziness, a central etiology should be suspected. So how do we deal with this? In the emergency department, when you only have one chance to examine a patient, if they were previously normal and now over the last several weeks to months they have several episodes of dizziness that sounds like BPPV, but it's either severe or it has these other characteristics that suggest a central etiology, a CT scan in this setting might and should be done, and an MRI should be considered, especially if when they have what are considered to be therapeutic maneuvers, there's no relief whatsoever, neuroimaging should be performed. Now, another cause of triggered intermittent vestibular syndrome that is triggered by standing up can be orthostatic hypotension. It again is peripheral. It is most often is benign, but it can be serious. You're looking for orthostatic vital signs which suggest hypovolemia. And obviously this might be optimally performed, the orthostatic vitals, after treatment, because if they're orthostatic before treatment, you're going to have to check for orthostatics after the treatment. But on the other hand, if you check for orthostatic vitals before treatment, you can say then that it's likely orthostatic in cause and prove that it resolved with treatment, which is another way to address what is a peripheral cause. You know, remember when you stand patients to check for orthostatic vital signs, they need to be standing for 2 to 3 minutes before you check for their standing orthostatics and or do sitting orthostatics in between the lying and standing orthostatics, because it takes a few minutes for the vital signs to normalize. And what are orthostatic vitals? A heart rate of increase of 20 to 30 beats per minute is by far the most reliable marker for orthostatic hypotension, but a decline in systolic blood pressure of 20 more millimeters of mercury or a decline in diastolic blood pressure greater than 10 millimeters of mercury also can be utilized to suggest orthostatic hypotension. Here are some other more rare triggered episodic vestibular syndrome diagnoses. Superior canal dehiscence, posterior tachycardia syndrome. Panic attack can cause this, but again, I would say this is a diagnosis of exclusion because people may be feeling panicked or anxious because they're having dizziness and they're worried they're having a stroke and could have the, quote, big one. Also, vertebral artery rotation or Bowhunter syndrome can be a cause of triggered episodic vestibular syndrome. Now, remember benign paroxysmal positional vertigo. We talked about this. When considering BPPV, there are two causes, posterior canal and what is also called the other being lateral canal, which is less common, which is movement of the otoliths in a position in the canals, which is abnormal. So BPPV, posterior canal problems in 80 to 85% of cases. Our Dix-Hallpike maneuver is diagnostic. Upbeating and torsional nystagmus can be seen. The Epley maneuver is the treatment or therapeutic maneuver that treats this type of dizziness. It repositions otoliths which have moved into a not normal location. So again, what's the pathology of BPPV? These are dislodged otoliths from the utricle which migrate into one of the semicircular canals, and they don't belong there. And then they begin to stimulate the semicircular canals in a way that's pathological. The posterior canal is the most dependent, so it's the most commonly problematic canal because the otoliths will fall into this dependent posterior canal. The otoliths cause motion to be simulated. And you can also get what is called the heavy cupula, which simulates motion as the otoliths become stuck in the cupula. And what this basically does is it disrupts the normal vestibular ocular reflex, VOR, which maintains normal gaze with movement of the head. So the Dix-Hallpike test. Now this is a complex test and I recommend you go to YouTube and look at videos of how this is performed. But you basically put the patient on the table, outstretched legs, head is turned 45 degrees to one side, then it's dropped 30 degrees below the table, and you examine nystagmus for 30 seconds. If the maneuver causes symptoms with nystagmus, when you drop their head 30 degrees below the table, 45 degree tilt, you know that it's likely BPPV because of this positive Dix-Hallpike test. Lay them flat, 45 degree, drop down on one side, do it again, 45 degrees, drop 30 degrees below the table. If on either side there are profound symptoms and nystagmus, this is a positive Dix-Hallpike, in which case the Epley maneuver may be done to help reposition the semicircular canal crystals, which don't belong there. So, head turn and drop down, assess for symptoms and of vertigo, dizziness with the Dix-Hallpike, examine for nystagmus. If both are positive over 30 seconds, the test confirms the BPPV diagnosis. Now, with the Epley maneuver, you're turning the head in all three planes. Why? Because there are three semicircular canals in three planes. The changing of the head position will allow for the otoliths to return to their normal location away from the semicircular canals. The cure may require repeated Epley maneuver sessions, much like physical therapy. And in fact, there are ENT specialists that perform this maneuver on a regular basis in vertigo patients. And I believe that in the emergency department, although you can do the Epley maneuver, the fact that it doesn't help in the presence of a positive Dix-Hallpike test and the likelihood of positive BPPV, the fact that the Epley maneuver doesn't work doesn't mean it can't work, and you should refer these patients because it may require multiple episodes of the Epley maneuver like physical therapy, in order to move the otoliths completely and resolve this BPPV dizziness. Now the next two slides talk about how you do the Epley maneuver. We don't have time in this presentation to go through it in detail, but what you're trying to do is you put the patient flat again, turn their head 45 degrees away from the midline, and then you turn it 90 degrees to the contralateral side, and you hold it in these positions for 30 seconds. And then you ask the patient to roll onto their shoulder while their head is turned so that you can move these otoliths. And again, you do this in a way that you're attempting to move the otoliths to a normal position. And I've actually given a reference here so that you could look more at how you do the Epley maneuver. And I suggest looking at videos on YouTube to help enhance your understanding of performing the Epley maneuver. So another question regarding BPPV diagnostics. In a patient with possible BPPV, the most likely physical exam maneuver to help confirm the diagnosis is, of course, D, the Dix-Hallpike maneuver, and that's explained on page 14 of the monograph. What are the dizziness patient risk management pitfalls? There are several pitfalls listed in this monograph. Let me go through some of them. Number one, I thought that because the dizziness got worse with head movement, it had to be peripheral. That's not true. Dizziness that's worse with head movement can be both central and peripheral. Number two, the negative CT ruled out a stroke. We know that that's not the case. The posterior portion of the brain is inadequately diagnosed with the non-contrast CT. In fact, if you're specifically looking at cerebellar findings, you have to request thin cuts of the posterior circulation or posterior cerebellum, because normal cuts at 1 centimeter can miss a small posterior circulation stroke. But in general, negative CT, non-contrast, does not rule out a stroke. Number three, I ruled out a posterior circulation TIA because isolated dizziness is never due to ischemia. Other brainstem findings will always be present. This is a misconception. You can have isolated dizziness in the setting of a posterior circulation TIA. Number four, the patient had acute dizziness for 24 hours. The neuroradiologist read the MRI with DWI images as negative, so there's no way this is a stroke. We know this isn't the case. Early on in stroke, up to 72 hours, DWI MRI can miss posterior circulation stroke. Number five, the patient had a bad headache and said he had some transient double vision, but the Dix-Hallpike was positive. Therefore, I gave him meclizine for his BPPV. You can't do that. Double vision is problematic, as is headache. These suggest posterior circulation stroke. Number six, the patient had both hearing loss and dizziness, so it had to be a peripheral problem, right? Well, remember, hearing loss can occur in the setting of posterior circulation ischemia, and you need to be careful to rule out a posterior circulation stroke. Number seven is my favorite. The patient was only 32 years old with no vascular risk factors, so there's no way that this is a stroke or posterior circulation event. Recall I mentioned colleagues have seen patients who are young who end up having posterior circulation events within a short period of time following admission for dizziness of concern. So young age does not exclude a posterior circulation etiology. Number eight, the patient felt very dizzy on gait examination but had no nystagmus at all, so I ruled out cerebellar stroke. Remember, only half of patients with cerebellar stroke will have nystagmus, and so you cannot say that it wasn't a posterior circulation stroke due to the absence of nystagmus in the presence of dizziness. Number nine, I know Hint's testing, the HIT test, was unequivocally positive. I saw a corrective saccade, so the problem must be vestibular neuritis. Remember, you need to have 5 findings be correct or negative for posterior stroke on the Hint's test in order for you to be able to say it's not a posterior stroke. The presence of a positive saccade or a positive test, which is good, which suggests peripheral etiology, in the absence of the other 4 Hint's test findings suggesting no posterior circulation event, they also must be negative or suggestive of a peripheral etiology or not suggestive of a posterior circulation central etiology. And last, the HINTS testing was worrisome, but the neurologist said to do an MRI, and if it was negative, to discharge the patient. He would see him on Monday. Here's what's important. Neurologists will often suggest that you do an MRI, and if the MRI is negative for any significant finding, that you can send the patient home. Remember, the problem is that if you have a worrisome HINTS test, if any of those 5 suggest a possible central etiology, you need to observe those patients for 24 to 40 hours because signs of a posterior or cerebellar or posterior circulation stroke can manifest themselves within hours after the presentation with an acute vestibular syndrome. You cannot, in the presence of a worrisome HINTS test, any of those 5 suggesting central, you cannot send the patient home just on the basis of a negative MRI. Let's go to our dizzy patient case study outcomes. These are good outcomes. Our first case, a 44-year-old dizzy male. He presented previously healthy 6 hours of continuous dizziness, unsteadiness, feeling like he's drunk, normal vitals, left beating nystagmus with gaze, and you were told if the CT is negative, you can send him home. Wait! If the CT is okay, home with meclizine. Remember, a negative brain CT does not reliably exclude a posterior circulation event. Acute vestibular syndrome, you need to do the 5-step HINTS exam and have all 5 of those suggest a peripheral etiology. If it's a worrisome presentation that the guy says, I'm walking like I'm drunk, I can't stand up, something's wrong, that worrisome presentation requires admission for observation. What about the lightheaded 70-year-old? 70-year-old female, lightheaded for 5 days. Worse with getting out of bed. The dizziness wakes her out of sleep. Stop right there. High likelihood ratio for BPPV. Hypertension and cholesterol meds. Vital signs okay. Normal neural exam. No nystagmus. Should a CT be ordered and why? Now honestly, if you're considering some sinister etiology and you feel you must do a non-contrast CT, go ahead. But remember, because this is likely BPPV with intermittent dizziness, dizziness that wakes her up out of her sleep, symptoms at rest, no nystagmus, vertigo is not necessarily always reported. In this case, the best test is a Dix-Hallpike test. If it's positive, you can treat with the Epley maneuver and or the normal treatments for BPPV. What about our syncopal 58-year-old? 58-year-old diabetic, nausea, vomiting, ×3. Syncope reported, but he actually said it was really just bad vertigo and he had to lower himself to the ground. This began 3 hours previously and was sudden. He had nystagmus to the right and higher amplitude with looking to the right. The HIT test was positive, which is good. Skew was negative. He had an okay gait. Should you call the stroke team? So here's the answer. Remember, with acute vestibular syndrome, you have to have a good exam and you must answer all 5 questions to say it suggests no central etiology. So, you had some nystagmus with gaze to the right, that's okay. No skew deviation, that's okay. A corrective HIT saccade on one side, that's good. It's positive, but it suggests a peripheral etiology. No other neuro findings. His gait was normal and no ataxia. All of this is reassuring. It's less likely a presentation of posterior stroke. You can treat this patient with steroids and antihistamines. Lastly, let's talk about dizziness in the setting of COVID-19 infection. I would refer you to the more detailed discussion of headache and COVID-19, during which I discussed all the aspects of COVID-19 that are relevant, especially when excluding life-threatening headaches. These are present and linked through our FERNE.org website and our YouTube channel. But let's briefly go through some key concepts about COVID-19 and how they relate to dizziness. The CNS mechanisms. ACE2 receptors are the binding site for the virus. The virus likes brain access through the nasal olfactory epithelium and the CNS capillary endothelial lining. There's hypoxic injury with COVID-19. There's immune injury and SIRS. We know there can be neuromyopathies that occur. And we know that the COVID-19 virus has a direct neurotropism, which means it prefers neurotissue. It can cause anosmia or ageusia, which is loss of smell and taste. We know that in general there are 3 types of neurosymptoms with COVID-19. CNS findings, dizziness, headache, altered mental status, CVA, ataxia, seizure, peripheral, taste, smell, vision problems, nerve pain, and skeletal muscle injury or neuromuscular problems. We know that there's both a viral infection phase and a headache that can occur with hypoxia and or the later cytokine storm. We know that there's headache in up to 1/3 of hospitalized patients with COVID-19. We know that COVID-19 can cause peripheral trigeminal neuralgia. We know that meningoencephalitis can occur. These are some case reports of patients who had seizures, syncope, needed to be treated with acyclovir and antibiotics. This is a case of a young man, 9 days of fever, headache, fatigue. You must consider COVID-19 during this pandemic. In this case, he was found unresponsive, emesis, and his hippocampus had suggestion of meningitis. There also in the temporal lobe. Here's a case of 2 children, one 12, one 15, with orbital cellulitis and pansinusitis. Both required surgical intervention. We know that CNS venous thrombosis can occur. A thrombus can occur. Stroke symptoms can be found. There can be some sinus problems with this. Low molecular weight heparin is indicated. And you can have straight up stroke or CNS thrombosis, arterial thrombosis. This is a case of a 64-year-old male with a wake-up stroke who had had COVID symptoms 16 days prior with fever and myalgias. What about dizziness and COVID-19? So we know that COVID-19 virus is neurotropic. It likes to go to nerves or nervous tissue. Where is that most commonly found? In the CNS and in the gut. So COVID-19 can cause dizziness via these following mechanisms. Direct labyrinth or vestibular nerve effects where it causes one side to become diseased. It can cause CNS or head or neck infections. It can cause dehydration or hypovolemia or orthostasis if patients have flu symptoms and they feel so sick that they don't even drink, they just sleep and hope to get better. It can cause dizziness through CNS venous thrombosis. And it can cause CNS posterior circulation thrombosis directly in the arterial tree of your central nervous system. Let's talk about dizzy patient conclusions. There's been a lot of information provided you today. I'd like to thank Dr. Edlow for making it clear as to how we should address dizzy patients. First, acute, severe, continuous symptom patients who present to the emergency department. That is an acute vestibular syndrome. That is your first diagnosis in your list of diagnoses in your electronic medical record. If the symptoms are not continuous but are intermittent, then considered a triggered or spontaneous etiology. Next, if you have orthostasis or BPV or posterior stroke, these are the 3 diagnoses that top our list that we must consider. Orthostasis being a systemic problem due to volume depletion. BPPV, which is a peripheral problem, which most often is triggered and is triggered often lying in bed. Or posterior stroke, which is suggested when any of the 5 hints tests suggest a possible posterior stroke etiology. So you must have those 5 exam findings to help exclude posterior stroke in this system that's been developed by Dr. Edlow. Remember that the BPPV diagnosis is confirmed with Dix-Hallpike and be treated with Epley, and that Epley may need to happen several times with an ENT specialist because it's like physical therapy. Remember, you have to have caution in the setting of a COVID-19 pandemic. As my daughter, who's a physician assistant in the emergency department, said recently, you must be very careful and consider COVID-19 as a possible cofactor or covariable in the cause of many symptoms, including neurological symptoms. And lastly, I think you can use EMR templates based on this information and dot phrases that help you make the exam process systematic and easily accomplished, and the history process for that matter. So my recommendations. Remember that dizziness pathologies fall into 3 diagnostic strategies with 6 diagnoses, and this fall into 3 general treatment categories. That's why I put it in parentheses on the slide. You must study the nystagmus findings and symptoms and BP maneuvers online and in the monograph. And remember, you have to consider nystagmus in the setting of either acute vestibular symptoms where all the bad nystagmus findings are of concern, or you consider nystagmus in the setting of likely BPPV, in which case you can have things such as rotatory or vertical or direction changing nystagmus that occur with this benign peripheral etiology. I recommend you make templates, dot phrases to exclude posterior stroke findings in your dizzy patients. And I think it's important to explain the diagnoses to the patient and provide them adequate follow-up and give them some expectation, knowing that dizziness can take several days to recur if it's an acute vestibular syndrome, and describe to them what is important if they have intermittent, whether it's non-triggered episodic or triggered intermittent vestibular syndrome. And I think you have to have particular caution in dizzy patients with the COVID-19 pandemic ongoing. So for questions, I would refer you to fern.org at gmail.com or the fern.org website. This information, including PDFs of this slide set, are available. I would recommend that you look at the monograph and contact EB Medicine if you have an interest in looking at more of their monographs, which are an excellent source of clinical material as we practice emergency medicine in the emergency department. My name's Ed Sloan. I want to thank you for the time you spent with us today, and I encourage you to look at all of the different segments of this podcast and or to listen to additional podcasts, including one on life-threatening headaches and the COVID-19 pandemic, and other podcasts which will be provided to you in the future. Once again, thank you.